Welcome to the Corticare webinar series, which presents topics related to EEG in neurodiagnostics, patient care management, research, and future applications. Today's event will last approximately an hour, and in about an hour, you'll receive an email with a link to an evaluation form for the webinar. And not only do we welcome your feedback, but if you're expecting to get asset CECs for this session, then you must complete the evaluation form and submit that. And then we'll go ahead and get the completed certificate, the certificate of completion to you in a few days. On this webinar platform, you can enter in your questions into the chat area. You can mark it as a question, and then I will handle moderating those questions at the end of this session. By the way, by registering for this webinar, you'll automatically be notified of future webinars. The next one is June 2nd, and we're going to be joined by Dr. Donna Murphy and Dr. Brandon Westover, who will be presenting on the use of EEG in clinical trials. Which is certainly a growing application over the last number of years and continuing to evolve. Today's presentation by Dr. Selim Benbadis is on psychogenic non-epileptic seizures. Dr. Benbadis received his training at the Cleveland Clinic, both in epilepsy, EEG, and sleep medicine. He's board certified in neurology, epilepsy, clinical neurophysiology, and sleep medicine. He's currently the professor of neurology at the University of South Florida and the director of the University of South Florida-Tampa General Hospital Comprehensive Epilepsy Program. He has authored over 100 articles, and he has a strong interest in not only medical writing and editing, but in education. And he has served on the faculty of a number of courses, and we certainly welcome his expertise and his presentation today. And I would now bring Dr. Benbadis on board, and I will sign off and let him take over.
Thank you very much, Jeff. Please confirm when and if you are seeing my screen.
You're good.
Excellent.
And so if you could just go into the view mode, there we are. Perfect.
We are going to talk about psychogenic seizures, as Jeff indicated. And then I will talk a little bit about psychogenic symptoms in general, because a lot of things we say about psychogenic seizures can be applied to the broader category of psychogenic symptoms. So here's an example of an epileptic seizure. This is the most common type of seizures, as all of you know, called the generalized tonic-clonic seizure. Convulsion, grand mal, there's all kinds of names for this. This is by default what people think of when we say the word seizure or epilepsy, and rightly so. It's the most common, it's the most dramatic. And then you have things like this that look superficially like a seizure and sound like a seizure, but are not. And a subcategory of things that mimic seizures are psychogenic, meaning of psychological origin. This is an example of that. So, like I indicated, we talk about psychogenic seizures. They're very well studied. If you put the word psychogenic in PubMed, 99% of what comes up as articles is related to psychogenic seizures. So psychogenic seizures are the most studied psychogenic symptoms, and there are good reasons for that. It's because it's provable. As I will show you, we can make the diagnosis with a very high degree of certainty, whereas other psychogenic symptoms don't have that. So this is what we're going to discuss in the next 40 minutes or so, 45 minutes, and then we'll have time for questions. So psychogenic non-epileptic seizures represent about 30% of what we see at epilepsy centers, which of course is a subgroup of difficult patients. If you do the math, that means it's as many patients as patients with multiple sclerosis. Traditionally, it's young adults and 3/4 or 2/3 women. The terminology is a problem, has always been a problem, continues to be a problem. There are meetings and interest groups and all kinds of discussions about terminology. This is one that we had a few years ago where we debated whether we should continue to use the word seizures. As you can see, this is not new. This debate is from 10 years ago, 2010. And I was on the side of abandoning the word seizures. I still am, very strongly, but there are very respected people that I respect who disagree and think the word seizures is just fine. I invite you to read any of these discussions if you would like. The most recent trend is to call them functional seizures, which, much to my chagrin, retains the word seizures, which is very confusing. And I do not like the word functional for other reasons. So terminology is a big deal. You can see various acronyms here. Psychogenic non-epileptic seizures, psychogenic non-epileptic attacks, non-epileptic seizures, non-epileptic attack disorders, functional seizures. I'll make a couple of points. It's important in the terms, in my opinion, to retain the P of psychogenic, because non-epileptic doesn't mean psychogenic. There are many things, I'll show you a couple, that are non-epileptic but are not psychogenic. So using NES to imply psychogenic is just simply wrong. NES is a broader group that includes psychogenic. I don't like the word functional because nobody really knows what it means. And I don't like calling this functional neurological disorder when we then have to ask people to see a psychiatrist and a psychologist. So to me, it makes no sense and it's beating around the bush. But I won't dwell any further on terminology other than to say that the word seizure is confusing. Every day that we diagnose people with psychogenic seizures, they say, well, I still have seizures, right? I still need seizure medications. In the English language, not in Spanish, not in French, for example, the two languages I speak, the word we use for seizures is a general term that does not refer to epileptic seizures. In English, the word seizure, trust me, implies an epileptic origin. Yes, you can qualify it by saying non-epileptic, but by default, the word seizure, medically speaking, implies an epileptic fit. So it's very confusing for patients. Okay, enough on terminology. As I said before, there are many paroxysmal short-lived symptoms in neurology that can mimic seizures, and you see some of them in gray here. And all of these are in the differential diagnosis of seizures. The reality, though, is that at epilepsy centers and in epilepsy monitoring unit, when we receive patients who have been misdiagnosed as epilepsy, 90% of them turn out to have psychogenic episodes. That's why this is so important. One reason for the misdiagnosis, this is a separate topic that we may tackle later at another talk, but one of the reasons for the misdiagnosis is the tendency for neurologists to overread normal variants. I'm giving my email address at the end, so you can ask me if you would like to see any of these articles. I can send them to you. But all of these discuss this horrible problem of the misdiagnosis of epilepsy based on errors in EEG. That's a big factor because these patients carry the diagnosis of epilepsy because of those EEGs. One area that's important is people often say that many patients with psychogenic episodes also have epilepsy, and it's been demonstrated several times that it's not as common as the myth says, 30 to 60%. It's really only 9 to 13%. This is our study of this. There are a couple of other ones. If you look carefully, and if you don't overcall benign EEG transients as epileptic sharp waves, it's only about 10%. Those are very difficult 10%, but it's only 10% of patients with psychogenic episodes who also have evidence for epilepsy. So what do psychogenic non-epileptic episodes look like? They can mimic any type of seizures, but the most dramatic, like I showed you in the initial video, are the generalized body convulsions, and they look like a grand mal seizure. Here are things when you take a history that should sway you towards epileptic seizures. The episodes are very stereotyped: incontinence, occurrence out of sleep, and injury, including lateral tongue lacerations like this. This is almost diagnostic of an epileptic seizure. On the other side, again, taking a history, these are things that alert the clinician that maybe these episodes are psychological. Odd triggers, things that occur in the doctor's office or during the EEG hookup, in the presence of medical personnel, in other words. Very high frequency, unaffected by anti-epileptic drugs, coexisting psychiatric diagnoses, the demeanor, the social history, the behavior of the patient, vague diagnoses like unexplained chronic pain and fibromyalgia, Those are all predictive of psychogenic episodes, as well as a florid review of systems that suggest somatization. So this is our little study of the predictive value of a diagnosis of fibromyalgia or chronic pain, or having an episode in the waiting room. Both of these predicted with a 75% predictive value that the eventual diagnoses will be psychogenic episodes. And this is what I mean by a florid review of system. This is a patient with a sheet listing 40 diagnoses, the second one being fibromyalgia and the third one chronic fatigue. So these vague symptoms, and a lot of them, tend to suggest somatization and a tendency for what is now called somatic symptom disorders, by the way, the psychogenic symptoms in general. So what about the episodes themselves? Do they separate? Is it easy to distinguish psychogenic versus epileptic? So the characteristics of the shaking is very important. There is shaking and there is shaking. And I'll show you all of this on video in just a minute. But here are things you want to look for. Slow onset and interruptions, what we call stop and go. Epileptic seizures, for the most part, as people have said, is like a story. There is a beginning, it builds up, and it dies down. It doesn't go up and down and up and down and up and down. So the stop and go is very important. Movements that are arrhythmic, irregular, asynchronous between the two sides. I'll show you that on video. Then there is a short list of behaviors that are very specific for psychogenic seizures. In other words, they occur often in psychogenic seizures and very rarely or never in epileptic seizures. So it makes them very specific. And here are the most common, and you are about to see them on video. Pelvic thrusting, head shaking from side to side in a no-no fashion, rolling over from supine to prone or the reverse, weeping, stuttering, eyes closed during the entire episode, back arching or opistotonic posturing, and the good rule of thumb of bilateral motor activity with preserved awareness. There are rare exceptions to that. So this is what we refer to as opistotonic posturing or back arching. This is so rare in epilepsy. I don't think I've ever seen it in epilepsy in 25 years of doing this. So it's almost 100% specific for psychogenic episodes. Ictal eye closure, and by that we mean persistent eye closure. During a generalized tonic-clonic seizure, the eyes are blinking clonically, usually, so unnaturally strong. They are not closed the entire time. So persistent eye closure, especially forceful eye closure that resists to our passive opening, is almost always psychogenic. This collage of video will show you most of the features I described. This is the rolling over. Here you see asynchrony of the upper and lower extremity. Here you see the eyes closed the entire time, some rolling over, combative behaviors. We always put in reports when we describe this non-tonic, non-clonic, more like flapping, chaotic movements. Here is the side-to-side head shaking. Movements are non-stereotyped, they change. This is more of a flapping, non-tonic, non-clonic. This is excellent bisynchrony, upper and lower. In the lower, the asynchrony is called bicycling. More bicycling and side-to-side head shaking. Again, bicycling, asynchrony, side-to-side, slapping, flapping, flopping. All kinds of random behavior here you can see. Eyes closed, stop and go. She kind of slows down, resumes. Interruptions. Back arching, that's actually the same one that I showed you the picture. Eyes closed, change in rhythm, it slows down, it speeds up, big amplitude, repetitive, non-tonic, non-clonic. Pelvic thrusting, good example of pelvic and truncal movements. And here is more back arching. One of the things we do in the epilepsy monitoring unit, as you know, is try to induce these episodes. It used to be done with IV saline, and the consensus has become that it's unethical to do that. So we don't do that anymore. We still do inductions or activations, but we use procedures that we use during any EEG, so they are not suspicious and they are ethical, and that means hyperventilation and photic stimulation. The usefulness of inductions or activation is that it's 99% specific. If we can if we can induce an episode with a placebo, whether it's hyperventilation, photic stimulation, a tuning fork on the forehead, or an IV placebo, it's highly likely to be psychogenic. Because, like I said, many people, rightly so, object to the use of placebo, and IV placebo especially. We have demonstrated, this paper is from 2000, that you can have the same exact yield using hyperventilation and photic stimulation. Now, some people would argue, but Dr. Benbadis, with those, you can trigger an epileptic seizure. Well, if you do, you learn something else. So it is useful. But if you induce an episode that does not look like an epileptic seizure, then it's a very strong argument to say that it's psychogenic. So like I said, inductions or activations are very highly specific. Also, there is a practical matter to this. We can only keep people in the monitoring unit for a few days. If after 2, 3, 4 days, they want to go home, the insurance wants them to go home, and they have not had their episode, instead of having an inconclusive evaluation, we can induce an episode with an activation, and all of a sudden the evaluation becomes conclusive. Also, as indicated in the last bullet here, sometimes, as you know, epileptic seizures do not have an EEG change or an EEG correlate, or the EEG is completely obscured because the patient is thrashing all over the place. And in that situation, the very fact that you induce the episode with a placebo is in itself an argument to make it psychogenic. So it is very useful. There are ethical concerns, which I recognize. 2 times in the past, I have had a debate, an old time and a more recent time. This is a more recent one, I believe, 2009. Pros and cons of whether provocative techniques should be used to help in the diagnosis of psychogenic seizures. I say yes with caution. Some other people think no, and it's a very interesting debate. Also, the advantage of induction or activation with placebo, including hyperventilation, photic stimulation, is that you can do it during a short EEG. It doesn't have to be 1 day, 2 day, 3 days. It can be an outpatient 2-hour EEG video, for example, with an activation procedure. You capture the episode. As long as you make sure it's the episode in question, you confirm that with the patient and the family, it can be diagnostic. And these are 2 articles, one from a regular hospital, one from a VA hospital, where we did just that. EEG video monitoring, as you know, is the gold standard for making a diagnosis of seizures or seizure-like episodes. There is good inter-rater reliability. We published this many years ago, and there is very good reliability, but there are pitfalls about EEG video, like everything else. It's only as good as the interpreter. One of the biggest misconceptions is that we make the diagnosis of psychogenic seizures by just recording an episode, the EEG shows nothing, and therefore we jump to the conclusion that it's psychological. That is not how it works. When there is an episode and 0 change in EEG, we can safely say most of the time, not always, that it is non-epileptic. But as I mentioned before, there are certain types of seizures that we know, focal seizures especially, that will not show an EEG change during the seizure. So we have to know this as an epileptologist before making this conclusion that an episode and no change on EEG equals non-epileptic. There are caveats to that. This is closer to reality. We record the habitual episode, very important, the word habitual. We show that the EEG did not change. That's one part. But the other part is the episode on video is not the type for which we have no EEG change. And with that equation, we can conclude that the episode is non-epileptic in nature. We cannot conclude just from that equation, habitual episode, no EEG change, that it's psychogenic. The psychogenic part depends on the phenomenology of the episode, what is happening on the video. As you know, these are the pitfalls I mentioned earlier. Simple partial seizures, that's the old term, including aura. So very small partial seizures can fail to show an EEG change on surface EEG. Everybody knows that. Secondly, electrographic seizures can be obscured by artifact. You saw these patients thrashing violently. It's very easy for the EEG to be completely obscured and becomes useless. So it's very important when we do EEG video to interpret the EEG in the video in the context of each other. Another pitfall, and we mentioned that earlier already, is when patients have more than one type of event. You can only conclude in regards to the event we recorded. So it's very important to ask the patient and the family to corroborate, yes, doctor, this is what she has been doing every day at home for the last 2 weeks. we need to confirm that. Otherwise, you may draw wrong, too broad of a conclusion. I threw that in because this is very interesting. We rely a lot on the EEG, as we should, and the video, as we should, but there are also EMG changes during motor episodes, and they look very different. This is a surface EMG recording. This is a generalized tonic-clonic seizure. This is a psychogenic episode, and this is a fake seizure, meaning, thank you. This is a, so you can see they look very different. And so this is a device that was commercially available. I don't think it is anymore, but it might be again. And the advantage of this, of course, is that you can wear, this is just a surface EMG, so you can wear this for months. And so for patients who have very rare events, this can be very useful for the diagnosis. So I mentioned this earlier, non-epileptic does not equal psychogenic. I did say, and I maintain, that the most common non-epileptic condition mistaken for epilepsy in an epilepsy monitoring unit is psychogenic events, but non-epileptic is not the same as psychogenic. Let me show you two examples of episodes that are not epileptic and not psychogenic. This is an older gentleman who has episodes of 20 minutes of not being able to speak, like this. He can follow commands, as you can see. Stick your tongue out. But he cannot speak. He cannot express himself. This is a pure expressive aphasia, and it's a TIA. Non-epileptic, not psychogenic. Here's another one. This is just two examples. There are many others. She has episodes of unilateral eye blinking that spread to the face. Is this epileptic? No. Is it psychogenic? No. It's hemifacial spasm. So non-epileptic is not psychogenic. That's my main point here. There are other conditions in the differential diagnosis, as I showed earlier. So now let's broaden the situation to psychogenic symptoms in general. Psychogenic symptoms are not limited to neurology or epilepsy. If you look at any textbook of neurology, it lists these symptoms as occurring due to psychological cause. This used to be called conversion disorder. As you know, it's now called somatic symptom disorders in the new DSM. And second to seizures, the two most common are these: movement disorders, tremors, dystonia, myoclonus, and gait disorder. So second to epileptologists, movement disorder neurologists are the ones that have some experience with psychogenic symptoms. But you can have all kinds of other symptoms, as you can see on the left. In movement disorders, like I said, it's tremor, myoclonus, gait. The diagnosis is a little tricky because they don't have the equivalent of the EEG, but they do have EMG. And EMG can show changes that are characteristics for certain types of cramps, dystonia, tremors, etc. They use certain things like distractibility, variability, coactivation, and they also use, by the way, placebo response and provocation, like we do in epilepsy. So they divide them into definite, clinically established, and probable, okay? They're, like I said, psychogenic symptoms can be all kinds of symptoms. This is a paper on psychogenic pseudo-stroke, where patients come in with a hemiplegia, for example, or aphasia, and they turn out to be psychogenic. And this is very important in the stroke world, because in the stroke world, you have to acutely make a decision whether the patient should receive a clot buster or TPA. So very important. In medicine, outside of neurologies, here are some examples of symptoms that can be psychogenic. Any specialists have their equivalent. If 30% of patients that come to an epilepsy center turn out to have psychogenic symptoms, it's true in other clinics. It's just not as easy to diagnose them, if you will. So in the pulmonary clinic, for example, shortness of breath, cough can be psychogenic, but it's difficult to make that diagnosis. It affects every specialty. In the area of chronic pain, the controversial diagnosis of fibromyalgia continues to be controversial, whether it has emotional components or not. So in most areas of medicine, to say that a symptom is psychogenic in origin is purely a diagnosis of elimination. What does that mean? That means the specialists, pulmonology, dermatology, cardiology, what have you, have to do the maximum workup, every test in their specialty, bronchoscopy, CT, MRI, to make sure you're not missing anything, which we understand that it turns out to be very expensive and uncomfortable when your only way to say this is psychogenic or psychological is because I've done every test in my specialty and I can't find anything. At least in epilepsy and seizures, we have a tool that allows us to make that diagnosis comfortably. Pain is the least provable psychogenic symptoms. How are you going to prove that somebody's pain is psychogenic? You can't, which is why I believe the diagnosis of psychogenic pain no longer exists in the DSM, and these unexplained pain syndromes continue to be controversial and a nightmare to treat, which is why we are happy we have pain specialists. So my contention is that if 30% of patients who come to an epilepsy clinic turn out to have psychogenic seizures, this is true in every other specialty. The problem is to make the diagnosis. So now if we go to the management aspect of it, none of this is new. This has existed since Charcot for at least a century, has been described. This is the old terms from the DSM, DSM-3, DSM-4. It was all under somatoform disorders. And under somatoform disorders, we meant they were not consciously faking. This is the biggest misconception. When I say psychogenic, many people hear faking, and of course that is not the case. This entire category of somatoform disorder, there were 5 categories including conversion disorder. By definition, the patient is not faking. The one that they are faking are factitious disorder and malingering. Those are conditions where the patient is actually actively trying to deceive us. So in the DSM-4, the entire category of somatoform disorders, which had 5 subcategories, including conversion, by definition means the patient is not voluntarily faking, whereas the faking is malingering and factitious disorder. It's difficult to be sure, but these are clear concepts. Okay, I talked about that. This is in the DSM-5 where the terminology has changed a little, and psychogenic seizures fall under either somatic symptom disorders or conversion disorder, and there is in fact a subcategory for functional neurologic symptom disorder or conversion disorder with seizures. So the terminology has changed, but the concepts are the same as they have always been. And for these entire categories of psychiatric disease, there are frequently histories of abuse, which you have to look for, or the mental health professional has to look for. In children, these symptoms, including psychogenic seizures, are generally more benign, and they tend to respond to treatment and go away more often than in adults. The outcome of psychogenic seizures is difficult. A lot of patients are lost to follow-up for multiple reasons. The most important prognostic factors are recent diagnosis. A patient whose episode just started a month ago will do much better than a patient who has had this for 10 years. The severity of the psychiatric pathology, the underlying pathology, the premorbid functioning, psychosocial status, children and adolescents do better than older patients. We have to understand that psychogenic seizures are only the tip of the iceberg, if you will. They are a manifestation of psychological distress. So getting rid of the episodes in itself is not the key. You have to really tackle the underlying psychopathology, and that, of course, needs the help of psychiatry and psychology. So the treatment is psychiatric. This is a psychiatric disease. It is in the DSM for a reason. So psychiatrists should treat this. The treatment of choice is a combination of medications and psychotherapy. The problem is that the psychiatric community is uncomfortable with it, with this whole category of disease, and I'll show you. And some don't really believe that it exists. There have been trials now for psychogenic non-epileptic seizures about cognitive behavior therapy, CBT, documenting that it works. And same thing for pharmacotherapy using SSRIs. So we do have treatments that can work. These are some recent articles on different types of CBT and different types of mental health interventions, if you will. Again, 2 arms, pharmacotherapy, the ones that's proven at this point are SSRIs and to some degree anti-anxiety medications, and also cognitive behavior therapy. So there is more and more evidence that they work, which is why it's so important to make the diagnosis sooner rather than later and send the patient to the medical professional. psychiatric professional, mental health professional. The neurologist should remain involved in this because, as you know, most of them have carried a diagnosis of epilepsy for years before being correctly diagnosed. As we said, about 10% have both, and they need help with weaning medications, make sure they don't continue to receive Dilantin when they go to the ER, address things like disability, working, and driving. So we still have a role, but we are, after the diagnosis is made, the neurologist should not be the main caregiver, the main physician. This is a diagnosis where the patient and the family need to understand and believe the diagnosis. Otherwise, they're not going to do the treatment. This is not a magic pill. They need to do cognitive behavior therapy and go see a psychiatrist and a counselor. If they don't believe the diagnosis, they won't be doing it, which is why the outcome is so tenuous. So you would think that these are the reactions patients are going to have, right? They come to us, they carry a diagnosis of epilepsy, by the way, on an average of 7 to 10 years. And now we're telling them none of this is epilepsy, it's all mental. You would think a lot of people don't like that. And it's true to some degree, but I've had very few terrible reactions like, I don't believe it, et cetera, et cetera. So if you take the time to explain, starting with the fact that we are not saying you're faking, we're saying this is stress, they are more likely to follow your recommendations. And to that end, patient information like this is very important. So we have a brochure on our website. There are others, but this one is free to download and print and use. And in fact, it is used at many epilepsy centers, I am told. And it answers these patients and families' questions, which are very legitimate. And they can see that we didn't just make that up now. It's not a diagnosis of exclusion because we didn't find epilepsy. We pay attention, we do it thoughtfully, and there are ways out of this and treatment if they understand the process and are willing to cooperate. Now, as I said, it's a psychiatric disease. It's a mental health disease. It should be taken care of by a mental health professional. But this is many years ago, when I went to the American Psychiatric Association meetings, I was impressed that they have very little on this entire category of disease: somatoform, somatization, malingering, psychogenic, factitious conversion. Look at the number of sessions they had on depression and anxiety, and this is what I found on this entire category of disease. So it seems completely neglected by our biggest psychiatric association. This was 2004, 5, and 6. 10 years later, I go again, San Francisco, to see if there was improvement. There wasn't. Here is the abstract book that you can search very easily. I found 300 pages and 500 plus abstract total. And these are the numbers I found on, again, this category: conversion, somatization, somatic, etc. 2. They're not getting a lot of attention. Then I went to their website. There are 2 websites: the American Psychiatric Association and the American Psychological Association. They're both APAs. And I'm looking for pamphlet. This is their patient information material, if you will. And there is absolutely nothing at that time. This is 2012. There was nothing on that category. Again, call it conversion, somatoform, etc., dissociation. There is nothing. This was one APA. Here is the other APA. So you see this one is psych.org. I believe that's the psychiatric one. And this one is the Psychological Association. Same thing. Every topic is on here, except that one. I became very depressed. So I wrote that article, which I'm happy to send you, saying that the mental health organizations are like ostriches hiding from this disease they don't want to hear about. And it doesn't make our life easy because we diagnose the patient and then we have nowhere to send them. In 2020, I again visited both sites, American Psychological Association, American Psychiatric Association. Good news, there is some improvement. Not in the American Psychological Association. You still will not find dissociation, conversion, somatoform, somatic symptom, none of it. Kids in the media, yes. Immigration, yes. Shyness, yes. Violence, yes. Bullying, yes. Nothing with that entire category of disease. So my question has always been, I still don't know the answer. Is this an omission that every year since 2010 they forget? Or is this a strategy that they don't want to deal with it? Fortunately, there is some good news. The APA, the American Psychiatric Association, on my most recent inquiry, 2020, I did find a category of dissociative and somatic symptom disorder. Not great, not a ton, but it's better than years ago when they had 0. So I am optimistic there is some progress. It is still incredibly difficult to get psychiatrists and psychologists to see those patients. So we'll open it for questions. Psychogenic seizures and psychogenic symptoms in general are common and uncomfortable. Doctors don't like those. They're time consuming. We don't know what to do. And psychiatrists don't want to see those patients. For seizures, we can make that diagnosis with nearly 100% certainty with EEG video. But for psychogenic pain, cough, blindness, tinnitus, you name your symptom, stomachache, very difficult. It's a diagnosis of exclusion, and it costs a lot of money because the physician, the specialist, has to do every test in their specialty to then say, can't find anything, must be psychogenic. It's a very weak strategy, but that's reality. Induction, activation is useful for the purpose of seizure-like events. The treatment remains a challenge because our mental health organization are not showing a lot of interest in this, although as I just showed you, there is some progress in the American Psychiatric Association. This is my email. If you want to send me your commentary, criticisms, praises, or request articles I have mentioned, feel free. And I am happy to answer questions at this time. Jeff, are you doing the moderation?
I am. And so we'll wait a moment to see if there's any questions that pop up.
I have never given this talk and received 0 questions or comment.
I must say, it was enlightening to me. A lot of this I was aware of, but really didn't understand how it was all assessed, and was really quite surprised by your comments regarding the lack of resources for the care of patients with these types of
I cannot tell you how many times a week I receive email random from everywhere. My doctor just gave me the diagnosis of psychological or whatever, psychogenic seizures. I went to my psychiatrist. They said they've never heard of this. They don't treat it. That's the answer they get from mental health.
Right. We did get a request to go back and take a look at some of those physical movement symptoms that you mentioned in regards to PNS, such as rolling over and...
you want to see the video again?
Yeah, or maybe the list, I think, of the movement.
The list, yes.
Yeah.
Here they are. Do you still see my screen?
Yes.
These?
Correct.
Yeah, so almost all of these you saw on the video. Pelvic thrusting, head shaking side to side, rolling over. Weeping you didn't really see, but that's also very near 100% diagnostic for psychogenic. Stuttering, same thing. Eyes closed can be a little tricky, but like I said, if it's the whole time and forced, it's almost always psychogenic. Back arching, yeah, those are the most specific.
There's another question here. Why patients with PNS act out seizures as opposed to other types of activities such as maybe eating disorders or alcoholism?
That's
or whatever?
A great question. They do. Those just don't come to me. Of course they do. They go if it's. That's why we have fibromyalgia and irritable bowel to some degree. If they have diarrhea as a symptom, they go to the GI. If they have back pain, they might go to the rheumatologist or the neurologist. If they have cough, they end up with the internist or pulmonologist. So they absolutely do. The ones that come to us is because they mimic seizures.
You mentioned in one of the studies that you were looking at 2-hour recordings. It sounds like the video is really important in assessing this. There was a question regarding the use of rapid EEG, things like the Cerebell system. Is that something that would be useful at all?
No, not for diagnosis of spells. You touched exactly on the right thing. The most important thing is the EEG video correlation. And in keeping to what you just said, if you give me one choice to have only the EEG or only the video of the episode, I and most epilepsy specialists will choose the video. So the video, as long as it captures the episode in question, is usually more important than the EEG. Sometimes the EEG becomes critical, but at least they're equal at a minimum. So really, you need the EEG and video simultaneously during the episode. Those rapid EEG, like Cerebell, are good to pick up EEG patterns, not clinical episodes.
Got it. Got it. So is there anything special about working with children as far as integrating with the school system or with social services?
So there are two things that are specific to children. One is the differential diagnosis is broader. In fact, we have a paper on that. When I say in an epilepsy monitoring unit, 90% of patients who have been misdiagnosed, don't have epilepsy, turn out to have psychogenic episodes. In children, there are more possibilities. The diagnosis is a little broader. If they do have psychogenic episodes in children, the prognosis is better. They respond better, the psychopathology is not as ingrained, and they tend to do better.
Good, good.
It's usually stress like school, frustrations, and things like that, not as ingrained and severe as in adults.
Okay. That's all the questions we have at the moment. I want to thank you again. This was an excellent presentation.
Thank you very much.
The recording will be available here shortly for those that want to review it. Please complete the evaluation form if you want credit for this with Asset for Continuing Education. And we will see you again in June.
And you absolutely are free to share my email address for requests.
Thank you again.
Thank you, everyone.
Goodbye.